Hello, everyone, and thank you for joining us this evening. We are thrilled to have so many of you with us for tonight's program, BRCA and Starting or Growing Your Family. I'm Sandy Grossman, and I am a member of the Board of Directors of Yodeah, an organization dedicated to educating and testing the Jewish community about hereditary cancer genetic mutations and providing access to affordable clinical grade testing. We're grateful for the support of so many organizations that have partnered with us, particularly the Greater Miami Jewish Federation and the Florida Breast Cancer Foundation. It's through our combined efforts that we're able to reach out and educate so many people, both men and women, about the BRCA mutation, encourage testing, and provide the information needed to make informed decisions regarding options to decrease the risk of developing cancer and passing it on to future generations. Before we begin, I want to share a few Zoom logistics with you. Let me just stop sharing my screen. There we go. So, tonight's program is presented in webinar format and is being recorded. Attendees will be muted throughout the presentation. However, we want to make sure that we address your questions. So during the program, you'll be able to submit your questions by pressing the Q&A button at the bottom of the screen, and we will get to as many of those as possible at the end of the program. Also, please keep in mind that Yodeah is not providing medical or insurance advice. The presentation is for educational and informational purposes only, and you should always seek the advice of your physician or other healthcare provider or your insurance company and agent with any questions that you may have regarding your personal medical situation or your insurance needs. Remember, genetic testing is not a substitute for meeting with your healthcare provider, having personal conversations, and screening and doing appropriate follow-ups. The same holds true regarding your insurance, which we're going to talk about a little bit later. So now that we've gotten those kinds of things, the important housekeeping rules out of the way, I want to start by introducing you to our panelists tonight. Dr. Liz Etkin-Kramer is the founder of Yodeah. She is a board-certified gynecologist practicing on Miami Beach for more than 25 years. She's also an assistant professor of OBGYN at FIU's Herbert Wertheim College of Medicine and is very active in the American College of Obstetrics and Gynecology. Additionally, Dr. Etkin-Kramer has been appointed to the American College of Obstetrics and Gynecology Presidential Task Force on Knowledge Gaps in Breast and Ovarian Cancer Risk Assessment Management, including genetic testing. Dr. Vanessa Weitzman has been a partner at IVF Florida Reproductive Associates since 2008, and before that was lab director at IVF Florida Reproductive Associates. She's an assistant professor of OBGYN at FIU's Herbert Wertheim College of Medicine as well, and is also an assistant professor of OBGYN at FAU's Schmidt College of Medicine. Jerry and Paul Reamer will be sharing their journey from finding out that Paul was BRCA positive to deciding to pursue IVF and now enjoying spending time with their beautiful 2-month-old baby girl, Lily. Morgan and Brian Weinblatt will talk about how they found out that Morgan was BRCA positive and the steps she's taken to protect her own health and that of their future family. So with that, it is my pleasure to turn it over to Dr. Etkin-Kramer.
Thanks, Sandy. Thank you to everybody for attending, and I'm really, really thrilled to be here. And thanks to Morgan and Brian and Paul and Jerry, even though Paul is you're the only name there, but that's okay. I know it's both of you. And Dr. Vanessa Weitzman, a friend of mine and a colleague who I've known for many years. I'm going to try is the operative word sometimes with computers. I'm going to talk a little bit about the background here. Okay. And so I want to talk first about hereditary cancer. Hereditary cancer, this is what we're trying to prevent. It's cancer that's associated with a genetic predisposition to the development of cancer because of a specific named mutation on a specific gene. It's inherited in an autosomal dominant fashion, which means if I have that genetic mutation, that my children, both boys and girls, have a 50% chance of having the same genetic mutation. BRCA is one of the many examples of a hereditary cancer, and there are a lot of people that are well known who have these. Angelina Jolie, Matthew Knowles, who's Beyonce Knowles' dad. Chris Everett found out that she carries a BRCA genetic mutation. And one of my favorite people, the late, great Gilda Radner had a BRCA mutation, although she didn't know because they didn't know about it at the time that she was diagnosed. So when we talk about hereditary breast and ovarian cancer, I want to stress, first of all, most cancers are sporadic, meaning it's due to an environmental issue, it's due to exposure to toxins, or we don't even know why someone develops a certain cancer. That being said, up to 20% of breast cancers and 25% of ovarian cancers are related to a gene that you can be tested for. So in breast cancer, 14% are related to a gene, of which BRCA is the most common. And ovarian cancer, 25%, I already said, is related to a gene. And in Ashkenazi Jewish women, 40% are related to BRCA alone. So this is a huge, huge burden that we need to understand and be able to risk assess ourselves, our families, me for my patients, because breasts and ovaries are my organs, and I need to be able to know to be able to take care of these patients. Ovarian cancer is not a screenable cancer, meaning there are no tests that let me diagnose it at an early age. So it's heartbreaking when we find ovarian cancer commonly at stage 3 because somebody has a genetic mutation and they could have prevented it. So with hereditary cancers, most men and women have not been identified. It's thought that perhaps 90% of men and women who carry one of these genetic mutations haven't been identified. And the lifetime risk of cancer in these patients is markedly elevated. The cancers often begin at younger ages. And in fact, in BRCA alone, breast cancer can start in the 30s to 40s. And the elevated cancer risks are seen both in men and women. But if we know, we can take measures to prevent cancer, and that's huge. And 50% chance of a child inheriting this genetic mutation with the same increased risk of cancer, we can help prevent it in future generations. And that's going to be the focus of what Dr. Weitzman is going to help us talk about in a bit. And there is specific criteria for who should be tested for these genetic mutations for BRCA, and it's usually based on personal or family history of cancer. For example, if somebody has a personal history of breast cancer at a young age, or a family history, or multiple cancers. And it's not only breast cancer that can increase the risk of a BRCA mutation, which in turn increases the risk of breast and ovarian cancer. But for example, if my father had a high-risk prostate cancer or pancreatic cancer or ovarian cancer, it would be indicated to test me. But again, some criteria is based on ancestry alone, and that's Yodeah. That's what we started because 1 in 40 Ashkenazi Jews, sorry, I pushed too many buttons. 1 in 40 Ashkenazi Jews carries this genetic mutation. Most don't have a family history, and therefore they don't know they're at risk. They have not been identified, and the risk of cancer in these individuals, it can still be markedly elevated, even if there's no family history. And it's guideline to test if there's only 1 of 4 Ashkenazi Jewish grandparents. So when we're talking about cancer risks, these are genetic mutations that we don't normally talk about when you're ready to have children, because it's usually adult onset. Unless a child has two BRCA2 mutations, they can have a childhood cancer. But these are not genetic mutations that we talk about typically related to childbearing, but it is something that we should think about. Most of the time when we talk about childbearing, we're talking about autosomal recessive mutations, meaning both parents have to be carriers for a child to have a disorder. But this is only needs one, remember, and it's an adult, usually an adult onset disorder. And there's the risk of cancer in both men and women. I've had patients as recently as this past week who said to me, I thought it can only be inherited through the mom. And I have to like take a step back because I'm in practice embarrassingly more than 25, it's now 30 years. And I have to explain to my patients, I'm so sorry, I thought we discussed this before, and let me reiterate it. It affects both men and women. But the risk of cancer for BRCA mutations are greater in women. The risk of breast cancer can go up to 70% lifetime risk. Ovarian cancer can be 50%. Pancreatic and melanoma are elevated as well. And in men as well, the big ticket item in men is prostate cancer, in particular with BRCA2 mutations. And so if I knew a man had a BRCA2 mutation, I would follow their prostate perhaps a little bit closer than one normally would, and we would consider MRIs and different screening. So it's important for both men and women of Ashkenazi Jewish descent to be tested. And the reason why this is timely when they've had children around the time of children is, again, to prevent children from inheriting this genetic mutation, but also for the person so that we can do different things at younger ages to prevent cancer. We want to prevent cancer, and we can do that. We have to identify these patients, these individuals, both men and women, before they develop cancer so that we can prevent cancer. Ideally by age 30, and if we know we can screen other family members, and again, for pre-pregnancy planning. If somebody carries a BRCA mutation, like any other genetic mutation, they can choose to do in vitro fertilization with pre-implantation genetic testing to prevent this in future generations. That is not something that everyone chooses to do, but it's an option. And now what I'd like to do is I'd like to introduce Dr. Weitzman, Vanessa Weitzman, to talk a little bit more about pre-implantation genetic testing and how that process goes, and about for any disorder, including BRCA genetic mutations. So Dr. Weitzman, you're on.
All right. Good evening to everyone.
You're muted.
I've been unmuted. Well, good evening to everyone. I'm Dr. Vanessa Weitzman. I'm a reproductive endocrinologist and fertility specialist, like Dr. Eichen-Kramer said. I have been in practice for over 15 years at IVF Florida. And I want to talk a little bit about some of what we do and what we can do to hopefully prevent these cancers that we're talking about. When we talk about what the options are, I'm going to give a little bit of basic information so people understand what the processes are, and then how we can apply them to specifically this topic. So many people have heard of IVF, which is otherwise in vitro fertilization. And that is basically the process where we're able to stimulate the ovaries to produce multiple eggs, where then we can go in and retrieve them, access the eggs, take them out, combine them with sperm in the laboratory setting, and then allow them to grow out to embryo stage. That embryo is then what we're looking at or using or want to access, and that embryo is also the subject of what we can test. So once we have those embryos, all right, they can then be frozen for the future with testing or without testing, and be accessed at any time, whether it's now, whether it's in a month, whether it's in a year, whether it's 10 or 15 years. Okay. And And that's the basic concept behind what IVF is. We're just trying to increase the number of embryos, access to eggs, creating embryos, and then being able to use them for now and for the future. The part that is relevant to cancer and prevention for the future is something that Dr. Kramer had touched upon, something called PGT, or pre-implantation genetic testing. This is the process by which we can actually identify in embryos if there is both what we call mutations, so abnormalities, for example, the BRCA gene, or if there's just general abnormalities in the embryo. Now, for gene testing, we have to know what gene it is very specifically. So prior to even starting the IVF process, that testing has to be done ahead of time, right? So when I have a patient that comes in to see me and they already know they have the BRCA mutation, we are then able to move forward what we call creating a probe, which is the actual kind of the search engine that'll look on the embryo's genetics to see, does it have the mutation that we're looking for or does it not, all right? Once that probe is created, and actually that mutation, usually we need the DNA from both the parents, from the individual who's affected, as well as usually maybe one or two other family members to get a more clear idea of exactly what the mutation is. And that's usually cheek swabs or blood testing, not such a major deal. But for the embryo, we then have the probe. That embryo that I was talking about for IVF, once it reaches that developmental stage prior to us being able to freeze it, we can actually biopsy the embryo, which is a process where we're taking anywhere from 5 to 10 cells from the area of the embryo that will actually be the placenta. We actually don't touch the part that will be the baby. It's kind of two separate aspects in the embryo. And then we freeze that embryo. Those cells that we biopsy then get sent for the actual genetic testing, where they can actually evaluate and they'll give us a read and tell us that embryo is normal, abnormal, has the mutation, doesn't have the mutation. So the important thing with the PGT is we can't create what people want. So it's not that I can create an embryo that I can fix. What we can do is test to see, does the embryo have the mutation or not? And then from there, it's a choice of whether you choose to transfer that embryo or not, which, Dr. Kramer was saying, sometimes, there's different ethical situations or circumstances. And while this testing can be done, it doesn't have to be done. So this is the pre-implantation genetic testing gives us that ability to at least know, does the embryo have it or doesn't it carry that gene? And if we have the option of transferring one or the other embryo, obviously the choice would be to try to transfer the embryo that doesn't carry that gene, and then basically take that mutation out of the future family line, so it doesn't have to be passed down through future generations. While 50, there's a 50-50 chance that embryo will have it, it doesn't always break down quite so evenly in the embryos. So it's never a guarantee that we'll have an embryo that is normal or abnormal. We may only have embryos that have the mutation, and sometimes we'll be lucky enough to have embryos that don't carry the mutation at all. So it's a little bit of a split which way it will go. Most times it runs about half and half. And so those embryos can, like I said, we're going to be frozen. And this kind of brings me to a little bit of a different side of the cryopreservation aspect of these embryos and doing testing in IVF. For some patients, they may find out at a young age that they carry the BRCA mutation. And if they are a couple, then it is a wonderful scenario where we can actually create the embryos and freeze them. And the younger you are, the more access you have to these embryos and the higher probabilities that pregnancy will work. Because unfortunately, as much as I wish I could tell you IVF always works, it's not a guarantee. So the more embryos we have, the higher the probability that we'll have a live birth, a baby from this process. But we also have the option for the cryopreservation, not just of the embryos, but we can also do cryopreservation for eggs. So for those patients who carry the mutation, but don't have a partner and are potentially interested in surgery prior to the age of 40, where we talk about possibly removing ovaries and tubes to prevent the risk of cancers, both ovarian and breast cancer, as long as you retain your uterus, which you can, we have the option also to go through this IVF process where we basically are able to remove the eggs, retrieve the eggs, and freeze them. So those eggs, again, are in their state of suspended animation and can be used at any point in the future. So if someone's not partnered but feels very strongly they need to go through the surgery or want to get those eggs out of the ovaries prior to removing the ovaries, we have that option as well, and we can freeze those eggs for future fertility options. And then from there, that, you can look at IVF as kind of a 3-step process, where the first step is the stimulation, where stimulators produce those eggs, and we're able to go in and retrieve the eggs. And then we have option 1 with the eggs to freeze them, or option 2 is inseminate them, where we're adding the sperm to it and creating them. Phase 2 be, once we do that, create the embryos. And then once we have those embryos, we have the option to biopsy or not, and we freeze those embryos. And then the third phase is the part where we actually transfer the embryo to the uterus for a pregnancy. And those 2 stop points can be at any given time, during over someone's lifetime. So whether you're doing the egg freezing at 30, creating embryos at 35, and not transferring those embryos until 40, those embryos will still act as the 30-year-old, the age that those eggs were retrieved. So the younger we get the eggs, the higher probabilities of pregnancy, the more eggs we'll have. Statistically, the higher probability that we'll have normal embryos to use for the future. So while this can be done at any age, obviously the younger we can do it, the higher the probabilities that this will work for the future. So this is where information, knowledge, understanding of the testing comes into play as young as possible.
I think that's a great point, that because when we talk about prevention of ovarian cancer, the same way we've talked about the prevention, there's no screening. Prevention, unfortunately, is removing tubes and ovaries, as you already said, Vanessa, at certain ages. And for BRCA1, it's 35 to 40, and BRCA2, it's currently 40 to 45. We don't know if there'll be newer studies to say maybe just take out the fallopian tubes, leave the ovaries, but that's not standard of care today. And so I can remove tubes and ovaries, and if you have frozen eggs, all Dr. Weitzman has to do, and I don't mean to make it so simplistic, forgive me, is fertilize those eggs. You have a uterus, you can have the tubes and ovaries out for years and put those fertilized embryos in the uterus. So it's an option. It's an option, and it's nice to have those options. So thank you for
Thank you, Dr. Weitzman. One of the comments that we hear frequently with respect to IVF is that it's an incredibly expensive proposition and road to go down. So while you may explain to us a little bit more about that, I think this is a good time to mention Making Miracle Babies, a program through the Greater Miami Jewish Federation, together with the Hebrew Free Loan Association, that they provide interest-free loans for people who are interested in going down these roads, and you have 3 years to pay back the loan. So it's a wonderful program, and we encourage people who are thinking about becoming pregnant. I think the program is geared towards first-time parents, that should you wish to seek help in this process from a financial perspective, reaching out to Miracle Babies through the Greater Miami Jewish Federation is a wonderful opportunity for people. So having done that little commercial for the Federation, and making sure people are aware, because I don't think most people know, I do want to introduce you to Morgan and Brian Weinblatt, who are going to share the story of how they found out about BRCA being in their family and their journey. So Morgan and Brian.
Thank you, Sandy. So good evening, everyone. We're very glad to be here. We first learned that I was BRCA positive right before our wedding in March of 2020, right before the pandemic and before all of our worlds changed. And at that time, it was very difficult news, but we were very much of the mindset that we wanted to understand options so that we could have the best health outcomes. And Dr. Kramer was incredible at sharing those options with us. And we first, did the preventative process, and I ended up doing a prophylactic double mastectomy. That was something that we knew that we wanted to go through with. And then thereafter, and after the reconstruction, we kind of went back to her and said, okay, well, what do we do now? Because we're ready to plan for a family. And we want to understand the options that we have, because we really do not want to pass down this gene if we have options?
So we do, thankfully. Just before we get into that, I just want to speak for a moment about what it means to be a supporter, a partner of somebody who is going through this when you yourself are not afflicted with the BRCA gene. But in this case, perhaps many cases, when it is the woman who is going through this, and of course, as men, we can never fully appreciate what it feels like to carry a baby, to give birth to a baby. Now add on top all of this and going through this, we're talking about 3 potential surgeries and the related injections related with the IVF process and everything like that. What I want to underscore is, for us, it wasn't even a thought. It wasn't even a pause, a moment of consideration. It was, of course, we're going to do this. And yes, it's extremely challenging, but we're going to do this for our health, for our future family. And all I can say is I'm incredibly proud of my spouse and what she has gone through. And I think that for those of us who are not afflicted with the BRCA gene, all we can do is be supportive with every step of the process, with what the other person is going through, because it is a sacrifice that they're making, again, for their health and for ours and for that of our future. So getting into the IVF process, all of this has been just absolutely fascinating to learn about, right? As was said previously in the presentation, now there's things that you can do about this. And the fact that in the course of approximately 3 generations that we didn't really know what BRCA was, couldn't test for it, couldn't do anything about it, to now there's something, if you have it, albeit that the procedures are pretty invasive procedures if you do have it, but that we can plan for the next generation so that, God willing, that they will not have to give it a single thought. They will not have to even think about it and go through everything that we have gone through and prior generations have gone through, that they didn't even know that future science. So that's one thing that I think is just incredibly fascinating, that science has evolved that quickly. So again, it was a no-brainer that we were going to go through the prophylactic surgeries. It was a no-brainer that we were going to go through the IVF process. It was a very interesting process to go through and learn about that. But very, very happily, we are expecting our first child, and it is through one of the embryos that was tested to be free of the BRCA gene. And we are very, very excited and grateful for all of the science. So all we can say is, please, 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 and I know this will be reiterated many times later on in the presentation, testing, 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 so important. And then obviously each individual person and couple, they have to think and make their own choices through this. But for us, it wasn't even a pause or a moment of consideration. It was just, of course, these are the things that we are going to do to maximize benefits for our health and that of our growing family.
And just a disclaimer, we're not selling anyone on anything, but for those that are on the webinar, you have options. And just to know that you have options is a really satisfying and comforting feeling. And we're happy to talk to anyone that has questions or is thinking about going through this process. We are open books, we've lived it, but we are not selling anyone. You just have an option.
Morgan and Brian, we are so excited for you. We're thrilled with your news, and thrilled that you shared that exciting news with everyone. I want to take you back for 1 second, though. Morgan, tell us how you found out that you were BRCA, that BRCA was in your family, because I think just as important as knowing that you're BRCA positive is sharing the information. And I think it's a wonderful story how it all came about.
I'll give the microwaved version, as I like to call it. So My father is actually the one who has the BRCA gene, although my mother did have breast cancer and she does not have the BRCA gene. I think they're on. Hi, mom and dad. And my father actually found out from a cousin, from a first cousin through Facebook, that they were all testing on their side of the family and that he should get tested. They found out that they were BRCA positive. He tested, he found out he was positive. He shared the news with my mom, my sister, myself. We all got tested, and myself and my sister, we both are BRCA positive. And so knowing that information came and that I was given the gene from my father, but knowing my mother had breast cancer was really a shock, because I thought that it would have been my mother, even though she was tested many years ago. It was really a shock. So knowing that I had, really, it was a double whammy from my father's side and my mother's side, I was extremely high risk. So it was even more so, I knew that I needed to go through with, preventive surgery and other options to really cancel out this gene and not pass it down, because it's an extremely pervasive gene. So that's the microwave diversion.
Thanks for sharing that. So now I want to introduce you to Paul and Jerry Reamer, who will also share their story of how they found out about, in this case, Paul being BRCA positive, and tell us a little bit about your journey and share your story with us.
Sure. Hey, everybody. Thank you so much for joining. We really appreciate everyone taking the time to learn about BRCA and learn about the options. And, also a disclaimer, we're not selling anything. We're just here to tell our story and how it made an incredible impact on our family. And so I'll take you way back to Jerry and I's second date. Wow, second date. And I was going through my 23andMe that I had recently done. And I thought there was some really cool feedback that I had gotten, such as I was 82% not going bald, and I could smell asparagus in my urine, and I like cilantro. And those were things that that 23andMe gave back to me. But as Jerry dug into it a little bit more, she goes, "Hey, Paul, you had the BRCA gene?" And I was like, "What's that?" And that's how we found out that I had the BRCA gene. And that's what, started my learning and our learning about BRCA and the impact that it could have on our family or our potential family. Even though we were only on our second date, we knew that if things got serious, it's something that we would have to consider. So I am, case in point, a male who has the gene that could potentially pass it on to the next generation. And, as things got more serious with Jerry and I, we decided to confirm the test. And, one thing that, people ask all the time is, where do you go to get tested? Well, I went to my girlfriend's gynecologist, and it was the greatest thing I did, because we confirmed that I had the BRCA gene, and, we wanted to then understand what the next steps were. And the next steps were to find out, where did I get this from? Did I get it from my mom's side, or did I get it from my dad's side? Similar to Morgan, I thought that it was my dad who was the carrier, because he had recently just survived cancer. And, there was no cancer on my mom, in my mom up until that point, and still, thankfully, not at all. And when they got tested, my dad did not have the BRCA gene, but my mom did. And then my mom, immediately after that, got the surgery to remove the ovaries, and I forgot what that's called. But you want to know what? Jerry initially finding out about the BRCA gene could not only, has educated me about what I need to do going forward, but also, could have prolonged my mother's life for a lot longer. And, then we started to take the next steps, once we were married, to go through the IVF process. And, it all started in our date that, now we have a beautiful little girl, and we'll go through, and I'll talk a little bit more about, kind of the results of our embryos, but we had 50% that had the BRCA gene. And so, it wasn't a fertility issue with us. We just really wanted to plan and make sure that if we could, we prevented any sort of cancer to be passed on to the next generation, or high likelihood or higher likelihood of cancer in the next generation. And we're happy that we did so, and we think it made an incredible impact on our family. And I think a little planning went a very long way. And similar to Brian, I'm extremely proud of Jerry and what she went through and the sacrifices that she made. She's an absolute superstar and a stunner. So we're just grateful that we used the information that Jerry brought to light. Jerry, probably saved or prolonged 3 people's lives in just looking at my 23andMe. And knowledge is power, and finding out your situation and then exploring your options, I think, is always a prudent thing to do, no matter what situation you're in. So for us, this was a very meaningful and important step that we took. And we're glad to share our story because it made a really good impact.
Yeah, and Paul pretty much covered everything, but I think that having Dr. Eckenkramer, she's really the reason why I even knew about the BRCA gene, because a week before Paul and I went on that seat, I had heard her speak about it. And so had I not known about it and been educated about it, I would never have known or recognized Paul's 23andMe panel. And now we can say that we have a beautiful girl who does not have the BRCA gene, and hopefully will never have to think twice about cancer or worry about any preventative care. And we're just so happy that we could do that for her and future generations, and hopefully more kids for us too.
And my girlfriend's gynecologist, pretty cool gynecologist, if I must say so myself.
I'll be your gynecologist, Paul. I think I said I was your gynecologist.
You are my gynecologist.
I am your gynecologist.
That's what I'm saying. But again, just want to thank everybody for joining and for hearing our story. And hopefully everybody learned something tonight. And thanks for having us.
You guys are terrific. The fact that, all 4 of you were willing to share your story, it's so personal, and that you all have been so open. I have no doubt that you are saving so many lives. As you said, Paul, it's not just about, the 4 of you or even your future children. It impacts all of your family members. So it's really powerful. And hearing it from you all, we could sit here and talk about this all day, but there's nothing more, I think, concrete and impactful than the 4 of you sharing your stories and being so brave about doing it. So where do we go from here? That's the question. And a couple of things. So if you have even one grandparent who is of Ashkenazi descent, then it's important that you get tested. And what we encourage you to do, hopefully I can put up my screen, there we go, is we want you to get tested. We want you to go to our website. You can use this QR code, and it's going to take you directly to the Get Tested page and order your kit today. It is a simple spit test. You go online, you fill in the information, they send you a kit, you spit, and you send it back. And if you put in our code, which is NO30 when you are checking out, then you will receive Yodeah's discounted price of $99. And I really encourage you, we all encourage you to do this sooner rather than later. It's so important. And we want to make sure as many people as possible get tested. I want to mention a little bit about the lab that we work with. It is a clinical grade medical lab that does the testing. They are, they work with health systems, researchers, physicians, and national health initiatives worldwide to provide affordable testing. Now, whether you go through our website and you order through color, or you see your own physician or genetic counselor, it doesn't matter to us. What matters is we want you to get tested. And one of the nice things about what color does is the 28 genes that they test, they're all actionable. So when you do your test, they will test for 28 mutations, and a genetic counselor will be back in touch with you if there's any issues to walk you through what does it mean and what steps could you take if there are any issues with any of those genes. So again, we say no matter where you decide to get tested, it's just important to get tested. The other thing I need to mention is about insurance. And this is where I have to actually read it because I have to share a disclaimer with you all because it's really important, especially for those of you in the younger generation who are thinking about starting a family, that you know this information. So, and you can find more details about it on our website, which is www.yodeah.org. But what we want you to know is that in 2008, the Federal Genetic Information Non-Discrimination Act became law, which generally forbids health insurers from using genetic test results for decisions regarding rates or coverage. There's also added protection under the Affordable Care Act and state law. However, GINA does not cover life, disability, or long-term care insurance. These types of insurance are regulated by state law. For many of us who are living in Florida, the good news is that Florida enacted a law that states that in the absence of a diagnosis of a condition related to genetic information, life and long-term care insurers may not cancel, limit, or deny coverage or establish differentials in premium rates based on such information. So that being said, we suggest that you have your insurance in place before you test. If you don't have your insurance in place, perhaps you want to consider testing up and having your parents test or your grandparents, because you may not even need to test. If neither of your parent carries this mutation, then you won't either, or you have less than a 1% chance. But if either of your parents carries this mutation, remember, you do have a 50% chance of being a carrier. And then, as you know, Morgan pointed out, you need to share the information, because if you or someone in your immediate family is positive, the ripple effects are tremendous. So the other thing I want to mention is that while you're on Yodeah's website ordering your test, we'd also love for you to consider a donation to Yodeah to help us educate and test more people. You can find that link on our website as well. So now I want to open it up to questions, because we've had a number of people write in with some questions, and we had a few that have come up while we've been on the call, and some that we hear quite often. So we want to go to the Q&A right now and open it up. You can put your questions in the Q&A chat, and whether it's for one of our couples or either of our doctors, we'd love, you know, to answer as many questions as possible. But I'm going to start with this one, and Liz, I'm going to give it to you. A number of people on this call are in their 60s, and they're thinking to themselves, do I still need to test? Is it too late? Does it matter? What's your response to that question?
Well, as somebody who's older, that's an easy response. Absolutely. Because first of all, the risk of breast and ovarian cancer in women and prostate cancer, male breast cancer in men still remains markedly high throughout your life. It doesn't go down the way it might go down in people who don't carry this genetic mutation. So if there are different things you would do. So for the person, and then for the children or family members, it's a no-brainer. And we're very lucky that that color has given us this a code to get it inexpensively over the years. But again, we're lab agnostic, as Sandy said. Just please just get that knowledge so that we can make sure it just helps us keep you healthy. So for future generations and for yourself.
Get tested. Vanessa, there's a lot of questions around IVF. And I know you touched on this already, but I think it's a really important question. Does this impact the baby itself when you're going through IVF or you're testing embryos? You touched on it, but I think people want to know for sure.
So when we talk about doing the IVF and creating the embryos, so I know there's always the concern if we're doing a biopsy, will taking these cells out, cause the baby to lose an arm or a leg? People worry about that. The reality is we are only biopsying the area that will be the placenta, not the actual baby itself. So the testing itself does not harm the baby in the future at all.
Perfect. Thank you. Does IVF and genetic testing, I mentioned this as well, but does it guarantee pregnancy, and what happens? How many rounds do people typically go through, and what percentage of their embryos do you typically see carrying a mutation?
So when we talk about IVF, like I said, we unfortunately can't guarantee a pregnancy, but the genetic testing itself. So I mentioned we're really focusing on the mutation. There's a secondary part to the genetic testing that usually gets done at the same time as mutation, which is where we're testing the embryo to see if it is normal or abnormal. And we talk about that, we're talking about the general karyotype, so the full genetics. So everyone has 2 copies of DNA, one from their mother, one from their father. And that, as was stated before, 23andMe is talking about, the 2 copies of 23 chromosomes. So all humans should have 46 chromosomes, and it's either 46XX or 46XY. So a secondary part of the genetic testing is to see is the embryo normal or abnormal, and then you filter again to see does the embryo have the mutation or does not have the mutation. So if we have an embryo that is genetically normal as far as the karyotype goes, and the mutation is negative, then we're going to see a pregnancy rate of 60+% for that individual embryo. And that's regardless of age. The difference with that age plays into, the biggest factor that plays into fertility or infertility in my world is going to be the age, the female age, not the male age, but the female age. So the younger the person is doing IVF and creating embryos, the higher number of embryos we will see that are normal, which is why the pregnancy rates are higher. The older you are, so women are born with all the eggs they're going to have their lifetime. And as we age, unfortunately, this number just goes down, as well as the quality. So we have a quantity and quality drop over time. The number of normal embryos we'll see goes down. But if we're doing the genetic testing, then we talk about and we have a normal embryo, then we talk about a pregnancy rate about 60%. Now, how many cycles it'll take to get to that point, that's really going to be age dependent. So obviously, the younger you are, the closer to, under 35 you are. Some people only have to do 1 cycle to get multiple normal usable embryos. The older you are, the closer to 40 or over 40. Basically by 45, it doesn't work. We don't get pregnancies, or the probabilities are under 1%. So we talk around 40 to 44 is about 44 is kind of our age limit for IVF to be functional. We may need multiple cycles. We may need 2, 3, 4, 5 tries at IVF to get that normal embryo.
Got it. Thank you. Somebody wrote in and asked, Paul, this was, I think, in response to the fact that you did the 23andMe test. And somebody wants to know if that's a good way to go about getting the test, or do you recommend other ways? Liz, you want to take that one?
Paul, do you want to take that one? I'll take it.
Yeah, you take it. I just want to say hi, Stu. And I got the test from my aunt as a gift. And so I did it not really knowing what I was getting myself into, but
which in a way is not a bad thing, because it turned out to be life-saving. But they call it hobby genetics. I just learned that phrase, hobby genetics, when you want to know if you can eat cilantro and things like that. And oh, by the way, they'll check for 3 specific mutations. They're not checking the whole gene, BRCA gene. And when I do it, just because there's an argument to test for only 3 mutations in Ashkenazi Jews, because by far those are the predominant mutations. But I'm a big fan of being done with BRCA, if you didn't get that impression already. So color genomics does the whole gene. So we're done. So we don't have to have this conversation again. I have not infrequently, I'll see a patient, Vanessa, I don't know if you've had this experience, who say to me, patients that say to me, oh, no, I've been checked for BRCA. When I get their results, it's only been the 3 mutations that are more common in Ashkenazi Jews. So if you're not Ashkenazi Jewish, these 3 mutations are kind of on the worthless side. Even if you're Ashkenazi Jewish, I think knocking it's more expensive nowadays to run individual little tests as opposed to doing the whole gene panel of 30 genes and being done. And we don't have to have this conversation anymore and be done. Sorry. That's
so Liz, I agree with you, because I have the issue with, unfortunately, I think for many people, they think that if 23andMe comes back negative, then they're truly negative. That's protective. So my concern with most patients, oh no, I did 23andMe. I said, yeah, but that's yes, it's the biggest group of them, but what if it doesn't mean you're completely negative?
Right.
It just means you don't carry those genes. There is a much larger, broader panel that needs to be completed so that we can say the probabilities of you having this gene are the lowest possible.
And also when somebody comes to see me, and the same thing with you, I'm sure, I was tested when I was pregnant. Although I'm doing a lot of the combined testing for genetic disorders, shout out to Debbie Wasserman from Nicholas Children, who runs the Victor Center there. Those are autosomal recessive disorders that affect the child, not affect the person. I'm doing a lot of it together now because I think it's quite important, as we've learned from Paul and Jerry and Morgan and Brian. Thank God, I'll spit on the ground. But you also, all of it can be done similarly, but you have to understand what you're testing for, either the autosomal recessive stuff and the cancer genes.
Right, so we test
Also,
right now
isn't there-
routinely.
Sorry, go ahead, Vanessa.
No, I was gonna say, we test routinely for the recessive genes for pretty much 90+% of the patients that come through. They then meet with the genetic counselor, and then the counselor will go through their history and see if is it applicable to add the cancer screening to it.
Right.
So
We're
trying hard to add to it as needed.
We're trying hard. We're trying hard, but not everyone gets the luxury because there aren't a lot of genetic counselors out. So when you're going through the website and you're choosing to be tested, there's a pre-test information, there's testing information, there's a post-test information. So at least you have that information while you're getting additional information.
Well, and also I want to point out, and Paul, this goes to your world of expertise. Also, there's a HIPAA issue, right? So if you test through color or your physician or a genetic
girlfriend's
counselor,
gynecologist.
Girlfriend's gynecologist, the information is protected, whereas at 23andMe, it is not protected information. And so that's another reason to think about going through one of these routes, as far as I understand. So Paul, since you're in the insurance world, you have a thought about that?
No, I'm not prepared to speak on that tonight. But great question, Stu. I love you.
Thank you, Stu. Somebody also asked if everyone is eligible for making an application to get a grant, to receive a grant from Making Miracle Babies. And I should have pointed out that that is for Miami-Dade County residents. You may want to check, for those of you who live outside of Miami, you may want to check with your own federations to see if they have such a grant available. One other question that's come up that we've heard from other people, Vanessa, when somebody comes in to do IVF and says, we want to have a baby, and you know that they're Jewish, are both partners automatically tested? When people say, I've had the Jewish panel, are both people automatically tested for this, and what does the Jewish panel mean?
So the Jewish panel, today we actually don't do just the Jewish panel. So we talk about pan-ethnic testing now because we are so mixed. You know, at this point, for things like Tay-Sachs, people think about as the most classic Jewish disease. We are not seeing it in the Jewish population. Right now, we're seeing an African-American, French, Canadian, Irish population, not the Jewish population. So we are doing pan-ethnic testing. And what that means essentially is recessive gene testing. So like, we were talking earlier that it's not the one mutation like the BRCA, which has a 50% chance of going through. And if you have it, then you have it. This is where both parents have to carry it. So we offer it to everyone. Like we offer basically genetic testing to partners, and they have, there's always the choice. You can do one person, you could do, and then the next person, if something comes up positive, you can do both people at the same time. We try to encourage everyone to get tested because the more information the better you'll be able to count, you should teach your children if you're carriers of specific diseases, and you may have to be aware of it for the future.
Thank you. So, Liz, when somebody goes through our website and orders a color test, the question is, do the results come to you, or how does that work?
Great question. Again, because of what you said with HIPAA laws, we don't get results. We're happy to review people's results. I can be, as Paul said, I can be a gynecologist to a lot of people, not just my patients, and as we've done before, but we don't get the results. It goes directly to the patient. So if I have a patient that I see in my office and they get tested through the website, and this has happened before, I have to find those results and I have to get permission and signatures, or the patient has to send them to me. Because I always like to keep it in the chart. So the patient gets the results. Sorry, I've got a barking dog. I don't know if you could hear that in the background. The patient gets the results and they get to speak to a genetic counselor, because you can, again, talking about cancer. Everybody, as we get older, has risks of cancer. We're talking about individual risks, a personalized risk. So if someone doesn't carry a BRCA genetic mutation, but they have a family history of cancer, we would manage them differently, perhaps. So there are different conversations to have once the results are in. And that's a conversation, a medical conversation.
Great. So before we wrap up, is there anything anybody wants to add? Anything we missed?
So I think there are some, okay. Oh, it was Stewie Kaplan. I didn't know you knew. Hi, Stu.
No, I think we got the questions.
Okay.
A couple of final thoughts before we wrap up. The Tay-Sachs has come up a number of times during this conversation. Imagine if we started talking about BRCA when our kids were young and made it part of the Jewish conversation. That is our goal, because we all know about Tay-Sachs, and through our combined efforts as a Jewish community and a medical community, we've been able to pretty much eradicate Tay-Sachs in our community. Our hope from Yodeah is to be able to do the same thing with BRCA. And we can only do that through programs like this, through conversations that you all are having, by encouraging your family members to become educated, to become aware. When you're sitting around your Passover table in a week and a half, to bring this up, we put together a little thing that Passover and the 4 questions are not just for Passover anymore. And they are for your doctor, for your family members, so that we can have these conversations anytime we are together and do our part to eradicate this BRCA mutation. So we'd really like to thank you for joining our program tonight. We hope that you will go onto our website. I'm trying to get my screen back so I can take you back to that slide so you know where to find. I'm going to post the QR code. Please go online, order your test today. Remember, knowledge is power and knowledge saves lives. We want to thank the 2 physicians, Liz and Vanessa, for joining us tonight, and our two couples. You all have been wonderful. It's not easy to share your stories, but I have no doubt that you've had a huge impact and that a lot of people will be touched by your experience. I also want to remind people, this is a personal choice, and IVF may not be the right answer for everyone. And so we want to encourage you to have those conversations and make the decisions that are right for you and your family. There is clearly not any one right answer. So however we can help facilitate those conversations, or as Liz so graciously offered, if you have questions, please feel free to reach out to us. We are available, and just want to thank you all for spending your time with us this evening. So have a great night.